integrate. So to start off, I want to give just some background information to share why this topic is so important for us to be thinking about. This is some data that represents 103 children who unfortunately died of cancer in the early 90s at Boston Children's Hospital. So we're talking about big pediatric specific institution, very resource rich. And we can see from this data that in the last months of their lives per parent report, within the following few months, that 98% of children were suffering in those final months or two. Fatigue, pain, dyspnea, poor appetite were some of the most common. And you can see in the second chart that of patients with those symptoms, in most cases, less than half of them per parents were having those treatments adequately treated. So really a long way to go in taking care of these children at the end of their lives. These are some patterns of care in the late 90s, also from that same study. Out of the 103 children who were looked at here, only 66% had any sort of palliative discussion documented in the chart. I found these next few numbers to be particularly jarring. On average, when a discussion was documented, it was only happening 58.1 days before the time of death, and a DNR order, if it was at all documented, was established just 33.6 days on average before death in those who died of progressive disease, and only 1.7 days before death in those who died of treatment complications. So really these discussions were happening sparingly, and when they were happening, they were occurring very late in the children's lives, just within the last month or even less. So that's why it's so important to be thinking about this topic. And this was 20 years ago. Things have gotten better, but it also wasn't that long ago. So this is why some reasons why early palliative care in children is so important for us to be thinking about. Children compared to adults with cancer really receive particularly aggressive care at the end of life. They are much more likely to be in the hospital versus at home than adults, more likely to be in the ICU, and also more likely to be continuing to receive aggressive treatment at the end of their lives. So it's really so important that these conversations are happening earlier in these cases. In that same study from Boston Children's, parents reported more calm and peaceful children in the last month of life when these discussions were happening earlier. And some specific advantages when palliative discussions are introduced early, there's time for trust and relationships to develop before some of the really difficult conversations are happening. We can integrate quality of life metrics throughout the illness course and not just at the end, and respond to those quality of life metrics to make sure that the kids are able to live their lives the best that they can. We can establish goals early with the knowledge that those goals will be fluid and change as things progress. And I like this quote a lot from this article. When we involve palliative early, we can honor the process of living in the face of childhood cancer and really make sure that kids are living their lives to the best of their abilities. So what are the barriers? Why were these conversations happening so late in the course when they did occur? One is physician perspectives. Traditionally, the role of palliative care for children with cancer was the oncologist role. And some oncologists have a lot of training and are very efficient at working this into their practice, and some might be less confident. Conflicting philosophies, the old notion that palliative care is not compatible with the goal of cure, and it's only relevant at the end of life when cure is no longer in reach. And also patient readiness. Families at the beginning are going through a ton of stress and processing a lot of new information. And then on top of that, introducing the concept of palliative care can really be jarring, especially with that preconceived notion that palliative equals end of life. And these next numbers surprised me a lot. The availability of palliative care can be a big barrier to receiving that care. This is from the mid 2008, 2009. It's the most recent data, but at that time, only 58% of children's oncology group institutions had pediatric palliative care teams available. Pain team and psychosocial support was luckily a lot more available, but specialized pediatric palliative care was there in just over half of these hospitals. and these are at pediatric specific institutions. So I want to talk a little bit about how feasible early integration of palliative care is. This is a small study out of University of Rochester, only 20 families, but I thought the numbers were impressive. The palliative care team instituted a new model that any new high-risk cancer diagnosis would have a palliative care consult in the first month of life. The caveats being that the primary oncologists had to agree, and also the families and patients, of course, had to agree to the consult. In this case, with the 20 families who were offered this early consult, 100% of families ended up meeting with palliative care and having that initial consult in the first month of life. They did note that there was a pre-standing very close relationship with the palliative teams and the oncology teams at this hospital, and that really helps them get this project off the ground and running, and really helped them get in from the oncologists and the families both to make this happen. But everybody agreed to the consult at the end. So finally, I want to talk about how we can integrate palliative care early, knowing that patient perspectives, provider perspectives, and availability of resources is going to be very different at every hospital and with every patient and family. So there are 3 tiers. I'll talk a little bit about each of them. At the bottom is institutional education-based policies that would affect every single patient in the hospital. Next up is trigger-based palliative consults, where very high-risk diagnosis or high-risk interventions such as bone marrow transplant automatically get a consult. And then finally at the top is on-demand consults, so end-of-life care, particularly challenging situations. So here are some examples of these things. At the institution level, there can be physician and nursing training, things like communication skills training and how to have quality of life and goals of care discussions, how to introduce quality of life metrics throughout the process and then act on those metrics, hospital-wide procedures for pain management and goals of care discussions when they happen, knowing of course that it's going to be slightly different for every patient and provider. Next up is trigger-based, like I mentioned, so high-risk diagnoses or high-risk treatments automatically get a consult. And finally at the top, on demand for particularly challenging situations. And this motto I like a lot because it allows for every provider, every hospital to kind of apply and integrate this 3-tier model in different ways, depending on the preferences and the resources available in the hospital. Ideally, we have some of all 3 of these things, but it can really be modeled to the needs of the clinic and the hospital and the families. So finally, to wrap up, a few take-home points. Early palliative care involvement for children with cancer leads to more peaceful children at the end of life, greater attention to quality of life throughout the disease process, and also closer relationships with providers. There's really time for those relationships to develop when they're introduced early. Barriers to early palliative care include oncology provider perspectives, family perspectives, and also lack of availability of palliative care teams. When it is introduced early in a collaborative way, families do tend to be open to early palliative involvement. And finally, how palliative care involvement early on in the disease course is integrated will be institution dependent based on the provider preferences, resource availability, and communication between the oncology and the palliative care teams. And here are my references. Thank you.
Great. Thank you so much, Alan, for such a wonderful talk on such an important topic. With that, I'm going to hand it over to Dr. Hutton, who's going to introduce our main Grand Round speaker.
Thank you so much. Thank you, Alan, for a wonderful warm-up that is so pertinent to our topic today. I was smiling as you were referencing Joanne Wolf's New England Journal article from 2000. We were faculty scholars in the Soros PDIA program together at that point. She, of course, got the New England Journal article. I never did that, but I'm also thoughtful that 2000 is the first year we had a Robbie Hutton lecture. So we were all cognizant of the same needs and issues and what was really important for kids and families at that time, and it's just grown magnificently since then. So with that, I am glad to welcome everyone to the 21st Robbie Hutton Lecture. And I'd like to tell you just a little bit about my nephew. Robert James Hutton was born in Greenville, South Carolina on April 15th, 1986, to my brother and sister-in-law, Ray and Judy Hutton. When Robbie was only 4.5 months old, he was diagnosed with acute lymphocytic leukemia. He traveled back and forth to Baltimore for treatment at the Johns Hopkins Children's Center, and that continued in collaboration with his doctors at Greenville Memorial Hospital. He was only 2.5 years old when he died in November of 1988 in Greenville. Robbie, whose picture you see and can see in the picture, he lived his short life to the fullest. He touched the hearts of those around him with his sweet smile and ready affection. He enjoyed the love of his devoted parents, grandparents, and friends, and he is sorely missed. We established the Hutton Lecture Endowment as a living tribute to him. Its goal is to promote compassionate excellence in the care of children with life-limiting conditions at the Johns Hopkins Children's Center through the education and support of the Harriet Lane House staff and the wider Children's Center community. So it is my great honor to introduce our speaker for the 21st Robbie Hutton Lecture. Dr. Robert McCauley holds the Cambia Health Foundation Endowed Chair in Pediatric Palliative Care at the Oregon Health and Science University in Portland, Oregon. He is a professor of pediatrics and medical director of the Bridges Pediatric Palliative Care Team. Dr. McCauley completed his undergraduate degree at Wheaton College as a triple major in philosophy, mathematics, computer science, and biblical studies, with a minor in social work. He then spent a year at the University of Oxford in England, earning a master's in philosophical theology. He returned to the US, attending both the Divinity School and the medical school at Yale, earning a master's of sacred theology with an ethics concentration, a master's of divinity, and his doctor of medicine. He is both a physician and an Episcopal priest. Baltimore captured him briefly. The Harriet Lane House staff can proudly claim him as an alum of our pediatric residency training program. He moved back north, spending 15 years at the University of Vermont College of Medicine, where he rose to the rank of professor. He was medical director of clinical ethics for the UVM Medical Center, and he founded the pediatric advanced care team there. Dr.
I think that maybe Dr. Hutton's internet connection might have cut out for just a second. So we'll give her just a second, and then if not, we'll turn it over to Dr. McCauley.
Potentially non-beneficial treatment. It's my honor to have you here, Bob. Thank you.
Well, thank you very much, Nancy. It's really a delight to see you all and think back to my old days at Hopkins. I was really looking forward to seeing folks in person, but in a way, being able to see folks without masks on and have this conversation is a wonderful opportunity as well. I want to thank Alan for a great Grand Rounds warm-up. It was almost exactly a quarter of a century ago that I was doing a Grand Rounds warm-up, and I think it's safe to say that he did way better than I did back in the day, so that was a great talk. And a big thanks to the Hutton family for endowing this lectureship, and we had a wonderful conversation yesterday. It brings to mind one of my favorite patients. I know you're not supposed to have favorite patients, but I'll confess I have had favorite patients. Was a wonderful young man who died of complications related to lung transplantation related to CF a few years ago, and I've kept in close touch with his parents. And in one of our conversations a few years after he died, his mom said to me, the thing that scares me the most isn't that he's going to die, because that already happened. The thing that scares me the most is that people will forget him, because every day of my life I think about him. And the fact that this is the 21st Robbie Hutton lecture is an opportunity to see that beautiful picture of Robbie and all of his toys and to remember him. So I just want to say thanks for that. All right, so this is the big part of the conversation where I'm actually going to try to share my screen. So we'll see if this actually works. All right, share sound, slideshow. Does that look okay to everybody?
It looks great.
Awesome. All right. So we're going to talk about responding to requests for potentially non-beneficial treatment. These are the objectives that everybody has to give. But in essence, what we're going to do is we're going to sort of fly through a bit of a history and perspective, moving way too fast. And so the slides are available at the link at the top of the screen if anybody wants to download them. And then we're going to spend most of our time on the more practical aspect of things as we get to the how to implement some of the stuff we're talking about. So I think there are three areas that we could talk about, or three categories of potentially non-beneficial treatments. Those that are proven ineffective, classic one would be antibiotics for viral URI, so we know those don't work. Another are things that are not proven effective. Here, remembering that the absence of evidence is not the same as the evidence of absence, and so there are experimental therapies that haven't been proven effective, but we're not entirely sure whether or not they work. And then lastly, those are treatments that are unlikely to provide benefit based on available evidence and or incur excessive burden. And that's where we're going to spend most of our time today, when parents, understandably, because they love their child, request these treatments, and we in the medical profession wonder whether or not these are going to work and whether they could actually cause more harm. So we're going to look at how we got here, what we've tried before, and why it hasn't worked. We're going to look at some recent consensus recommendations, formulate a concrete plan, look at extreme cases, and those are the ones that make the headlines and also keep us up at night. So how did we get here? So futility, and I'm going to use that term a little loose at first and more specific as we go along, has been around for a long time. Hippocrates, way back in the 5th century BCE, said there are certain times where patients are overmastered by their diseases and that physicians are incapable of treating them or helping them. Certainly that was the case 2,500 years ago, and it is still the case today. So the history of futility, you can kind of divide between up until the 20th century and then the 20th century and forward. So up until the 20th century, even the mid 20th century, we really didn't talk about it very much because we were in a more paternalistic system. And so if a physician didn't think a certain treatment would help a patient, we just wouldn't mention it. This was pre-internet, so patients probably wouldn't know about it, and we just wouldn't offer things that we didn't think would help. In about the mid 20th century, there was a shift from a more paternalistic model into a more patient autonomy-based model. And for the first time, and this might come as a surprise to folks who are newer in the profession, that the first time there was actually a court case that said that patients had the right, these are adult patients, to refuse a treatment that could conceivably help them or potentially sustain their life was in the mid 1970s. So for the vast history of Western medicine, physicians just did what we thought was right. Patients couldn't say no, and if we didn't think something was a good idea, we wouldn't mention it. Subsequently, there was a question about whether it works both ways. So the right to die movement of the 1970s and 80s was about whether patients had the right to say no to things that physicians thought were a good idea. Now we're talking about do physicians have the right to say no to things they don't think are such a good idea when patients are asking for them. The AMA Code of Ethics says that there's no, physicians don't have an obligation to provide treatments if there's no reasonable chance of benefiting patients, which sounds reasonable on the surface, although the devil, as always, is in the details. So what have we tried following the 1970s and patients' right to refuse? What did we try to say physicians had the right to in the subsequent and following decades? So the first reference actually to futility in the medical literature, in the modern medical literature, occurred in the 1980s. And there were a bunch of position statements that quickly followed, including some really interesting legislation, most famously in Texas, where they passed the Texas Advanced Directives Act in 1999, interestingly signed into law by then Governor George W. Bush, which basically said that if physicians felt that a treatment was quote unquote futile, they could go through a very specific process, including have it be reviewed by the Hospital Ethics Committee and have a second opinion, very clearly delineated process. And if that committee determined that it was indeed futile, then the hospital could remove that treatment after a period of time, 10 days or less if the patient's family agreed. And there was no opportunity for judicial appeal. So this was taking it out of the courts and putting it entirely in the hands of the medical system. Around this time, there was a lot of interest in the medical literature. First reference of 1987 to futility, and then gradually over time, and these are the number of references in either the title or abstract of PubMed articles to futility. So we started talking about it a bit more. And it didn't really work. And there are a few reasons why it didn't work. The first is we couldn't agree on the definition. So here's a seminal article back in the late 1980s that said that futility has a variety of meanings, including the narrow sense, physiologic inefficacy and inability to postpone death, and a broad sense, inability to prolong life for a time, inability to maintain an acceptable quality of life, or very low probability of achieving any one of the foregoing. Now, if you look closely, there are actually three separate and distinct definitions in that one sentence. One is what we would call physiologic futility. So it's not going to work. It's not going to achieve its intended goal. Classic example would be CPR in the context of cardiac wall rupture, just not going to work. The second definition is what some people call qualitative or normative futility, which is to say it might work. Who knows, it might actually be likely to work, but by working, what are we going to achieve? Is that a quality of life that is worth sustaining? And the last is probabilistic futility, where it says there's a very low probability, and we'll have to talk more about what low means, of achieving any of this. So these are some statements that came out in the 1990s about futility, and the interesting piece of it is that they use sometimes different definitions than other articles, and sometimes, in the case of the AMA statement, they actually don't use a definition at all. So we're talking about something we don't necessarily know what we're talking about, and we may be talking about it in a different way than the person we're talking with. So I would like to say that futility is defined by the patient's goals. So aside from physiologic futility, where it just will not work, which is a very rare case and may actually have some value-laden aspect to it as well, everything else is based on the patient's goals. So if somebody were to say to you, is mechanical ventilation futile in this patient? I think that's a bogus question, because we need to know what the patient's goals are in order to figure out whether we can achieve those goals. So if you were to say, a 28-week preemie who needs, a few days of mechanical ventilation in order to have probably a long and happy and healthy life, then clearly, if that's the goal, that's not futile. Whereas a patient who is at the end of their life and will never come off the vent and their goal is to go home, then maybe putting them on a ventilator would be considered futile. The AMA recognizes that in their more recent statement than the one we looked at before. They said there are necessary value judgments involved in coming to the assessment of futility. So what ends up happening is we sometimes end up reasoning backwards because we don't really know exactly what the definition of this term is. So there may be situations where we say one thing and patients hear something else. So imagine yourself saying that the chance of this treatment working is like 1 in a million to a patient. I think that what we anticipate they're going to respond is, well, why would we do that? That's, the odds are very much against us. So as an example, I hope my tech works. I'm going to give a clip from a movie to illustrate this. There's that old saying, many a truth is said in jest. So this is a humorous movie. I want to be really clear that I'm not comparing patients to the characters in this movie in any way, nor their parents. But I think there's a lot of wisdom in silly humor. So this is a movie that was big back in the day called Dumb and Dumber. And this is a scene that I think has application to the practice of modern medicine.
I want to ask you a question. Straight out, flat out, I want you to give me the honest answer. What do you think the chances are of a guy like you and a girl like me ending up together?
Well, Lloyd, that's difficult to say, and we really don't...
Hit me with it. Just give it to me straight. I came a long way just to see you married. Just, least you can do is level with me. What are my chances?
Not good.
You mean not good like 1 out of 100?
I'd say more like 1 out of 1,000,000.
So you're telling me there's a chance? Yeah!
So I sometimes refer to that clip because I think that it takes us by surprise as physicians when we don't get the response we're looking for. But if we think about it, if the chance is 1 in a million that a treatment will save a patient's life, but without the treatment, the chances are 0 in a million, it's not really very surprising that parents would opt for that. I was thinking about this last week. I had a patient who was in the hospital with very advanced cancer who happened to be in my son's class as a sophomore in high school. So I knew his parents a bit before he came into the hospital. And it was very clear to the physicians that he was dying. And the family kept asking for new and experimental treatments. And at one point in a very heartfelt conversation, his mother said to me, you might do the same thing. Like, kind of the subtext was, you're trying to talk me out of this, which I don't think I was, but you might do the same thing if you were in my shoes. And I think she was expecting me to argue with her. I think she was expecting me to say, no, I wouldn't, because I'm a physician. And what I ended up saying was, yeah, I'm pretty sure I probably would if it were my kid. So I get where you're coming from. So sometimes what we end up doing in medicine is we say there's a 1 in a million chance. We're expecting someone to say, well, we shouldn't do that. And then they say, well, I still want to keep going. So then we resort to sort of backwards logic. So the logic here is physicians aren't obligated to provide futile treatment. The AMA Code of Ethics says so. If we say this treatment is quote unquote futile, then we can say I'm not obligated to provide it. So I asked a question, didn't get the answer I wanted. Now I'm just going to say, well, I don't have to. I'm not ethically obligated, which is one of the reasons why some people refer to futility as the F word in medical ethics, because it kind of squelches conversation. And now it gets a little scary when we talk about what we're willing to deem as futile. So if we were together, I'd ask for a show of hands and we'd have a conversation. But just since we're not, I would ask folks, especially the medical providers in the audience, to imagine a situation. Say there's a treatment, say it doesn't have a whole lot of bad side effects, but we're not sure how it's going to work, or if it's going to work at all. So what likelihood of efficacy would we need to have in order to do it? Or conversely, at what point is the likelihood of it working so low that we are willing to say it's futile, therefore we don't need to provide it, even if we're asked to? So if you think about it, if you were to say 0%, then you would be assuming a position of physiologic futility. Like, if it has any chance, I'm going to do it. If you were to choose a very low percentage, you would be a probabilistic futilist, because you're saying, well, even if it has a small chance, that's one thing, but it's got to have a decent chance of working. So they did a study. This is back in the days when people were really talking a lot about futility. And it was published in the Journal of Clinical Ethics. And so on the vertical axis, they have the percentage of physicians choosing a cutoff point. And on the horizontal axis, they have the likelihood of benefit. So this here on exactly the y-axis says about 20% of physicians said, it's got to have a 0% chance of working for me to not offer it. So those are the physiologic futilists. The most common response, a little over a third, are physicians who said, if it's got a 1%, 2%, 3%, up to 5% chance, then anything less than that, I'm not going to offer it. So all that, I think you could have a conversation about. It's the tail out here on the right side of the chart that's really worrisome. So about 5% of physicians said that if there was a less than 60% chance of working, I'd be willing to call it futile so I don't have to offer it. In other words, saying, I don't want to offer it, I'm trying to find some justification for not doing so. And I'm kind of contorting this definition in order to fit my purposes. And the last thing that we ran into problems with was implementation. So we talked about the Texas Advanced Directives Act before, where it takes it out of the hands of the courts and allows hospitals and hospital ethics committees to determine whether or not something is futile or not, and if so, to justify removing that treatment over family objections. So a few years ago, I was at a bioethics meeting, and I bumped into a person who was the director of ethics at a very large Texas hospital. And Texas is known for the Texas Advanced Directives Act in the ethics community. And so naturally over lunch, I said, so how's the Texas Advanced Directives Act working out? Like, I'm curious, what's your personal experience of this? And his response was, well, if you don't count having to move your family to a secure location under cover of darkness, I'd say it's working out pretty well. And what he meant by that was that just because there's a law that says something doesn't mean that people have to agree with it. And if the physicians are saying we're going to remove this treatment from your loved one because we have the legal right to, it doesn't mean that that person's family is not going to react very vehemently in the negative. So what ended up happening was, and this is a journal article from the New England Journal of Medicine from the late 1990s, they talked about the rise and fall of the futility movement. We got really interested, and then we weren't as interested. And as you can see, there was a whole lot of interest in the mid-1990s, and then it sort of faded out. So what happened? First of all, we couldn't agree on the definition. Second of all, even if we had agreed on the definition, we couldn't agree on who should apply the definition. Is it the courts? Is it a hospital ethics committee? Even if we had agreed on the definition and who should apply it, we couldn't agree on what to do when people disagreed on the final decision. So we gave up and we fell back on narrowly defined procedural policies about physiologic futility, which rarely applies, and those policies are rarely used. So ultimately, you might say that our discussion of futility was futile depending on your definition and who applies it. But then something strange happened. People started talking about it again. So you had this big spike, what we thought was a big spike in the medical literature in 1995, then it dipped, and then over the last 10 or 15 years, people are talking about it, and we're talking about it more than we did back during the futility movement. So why are we interested in it again? I think there are a variety of reasons. One is money. So this is a chart of healthcare spending as a percentage of gross domestic product. And as you can see, as we all know, the US is a huge outlier, and we're getting to be more of an outlier. If you wanted to go back to the 1980s, we were fairly close to everybody else in these other Western developed nations, and we're just outpacing everybody. This last data is from 2014. Most recent data I could find was in 2019, when we're now at 17.7% of GDP going to healthcare. Another is there are situations, modern medicine can do so much. It's remarkable what we can do, but there's still some things we can't. And some people ask us to do things that we know that are even beyond the amazing things that modern medicine can do. And the last is, I think we're worried about doing harm. Are we doing things to people, and especially in pediatrics, to children, that are causing them to suffer, that are causing them to have lost opportunities? You know, Alan did such a nice job in the warm-up of talking about the burden of end-of-life care. Are we, in an attempt to help somebody, are we actually harming them? And there have been some very well publicized cases, and if we have time for some Q&A, I know Nancy has some really interesting insights on Charlie Gard and patients like Charlie Gard and people who surprise us, but there are big newsworthy cases of parents saying, we want more treatment for our child, and some of us feeling like, are we actually causing harm? So in response to this, there are some recent consensus recommendations. This is a consensus statement, variety of critical care societies from 2015 in adults focused on intensive care units, but I think it has some application for us, which I'm going to sort of use as a launching pad. They made 4 big recommendations. The first one we're going to talk about, which is consensus recommendation number 2, was to do a few things. One is to use the term potentially inappropriate rather than futile, and we'll talk more about what futile will mean. And they like potentially inappropriate because potentially says we're not actually totally sure sometimes. Like, the longer you do this, the more likely that you have been surprised in your career by some patient who did better than we thought. They also like inappropriate rather than futile. I actually prefer the term non-beneficial because I think what we're really talking about is benefit. So I'm going to talk about potentially non-beneficial treatment. And so they talk about a stepwise approach. So you advocate for an appropriate treatment plan, and then if there are continued requests that are contrary to what you consider to be an appropriate treatment plan, there's a whole process, second opinion, and then you have a process of appeal, some kind of committee approval or committee review, through an interdisciplinary hospital committee with surrogates having an opportunity to partake in that. And then also there's the possibility to pursue extramural, or otherwise known as judicial appeal. So this is not the Texas Advanced Directives Act where the courts aren't involved and all the power is in the hands of the hospital. This is a way of hopefully furthering the conversation without taking away the judicial option. Another of their recommendations was we stop talking, or we don't provide futile interventions, namely those that won't achieve the physiological goal. Very narrow definition of futility in this statement. So it's not about probabilistic, it's not about qualitative, it's only about if something won't achieve the goal, we shouldn't do it, and we shouldn't do things that are illegal. They also talk a lot about the term futile, because that's a term that I think can hamper conversation, which we'll talk about in a minute. Their last recommendation was that we should lead public engagement efforts and start the conversation earlier rather than waiting until we're in a pickle, which is always a good idea. And then the one we're going to spend the most time on, which I'm going to flesh out with some additional opinions, is their first recommendation, which is that institutions should implement strategies to prevent intractable treatment conflicts, including proactive communication and early involvement of expert consultation. So rather than waiting for a problem to arise, is there a way that we can be more proactive? Remembering that old saying that an ounce of prevention is worth a pound of cure. So I think the first thing we can do is look at some of the self-defeating practices that we sometimes, globally, we here engage in, and how we can avoid those. So some are more blatant, which I don't think many of us do anymore, which is, and there are times when I think that we do this when we're in a rush. And I want to be clear, like, this may be a little pie in the sky. This is going to be a very nuanced approach. If I'm a resident and I'm in the ER and I'm admitting a patient and I've got 5 other admissions stacked up, it may be impractical to go down this road. Similarly, I may not go down this road if it's unlikely that some of the things I'm going to talk about are going to happen. And especially in pediatrics, where we have a presumption towards more intensive treatment, obviously we're not going to talk about code status with a otherwise healthy 1-year-old who's getting admitted for bronchiolitis. But for patients who we are really worried about, who are at high risk of bad outcomes, who may not have a good prognosis, who may be asking for treatment that may not be beneficial, then this comes into play. So if your heart stops, do you want us to restart it? Very unnuanced, gives the impression that we could actually resuscitate somebody if we tried, doesn't really go into their goals at all. There's also more subtle things where we might say, so you do want us to do CPR in the context of cardiac arrest, but then we say, well, unfortunately, we're not going to do that because that's not going to work. Like, there's an old saying, a choice is only a choice if it's really a choice. So we shouldn't ask questions unless we're really ready to hear and respect the answers. So in a way, you could actually critique the title of this talk that I'm giving, because if you look at it, responding to requests for potentially non-beneficial treatment is actually very reactive rather than proactive. So what I'm going to try to do is be a little more proactive. George Harrison once said, since our problems have been our own creation, they can also be overcome. So if we sort of contributed to this, how can we make it better? So here's a concrete plan. Steps to prevent futility conflicts. First thing, just to say, because legal is always on people's minds, we should be aware of the laws in our state. Certain states have very specific laws that sometimes say that there are carve-outs that allow you to make unilateral decisions or make decisions on your own. Most states don't, so we need to know what our state's laws are. In general, if a family sues to keep treatment in place, they'll usually win. And the reason for that is, if you think about it, if you have a family saying, please, this is my child's only chance, and you have a bunch of physicians saying, we're pretty sure this isn't going to work, like, judges didn't go into the judging business to take away hope. And so they'll often understandably say, well, I'm going to give this child a chance, and I personally am not critiquing that. At the same time, if a family sues because treatment was withdrawn later, they usually don't win unless the physicians were dishonest or callous, which obviously we should never be. And I often say that if something ends up in the courts, then I failed at my job, because if you get to court, that's adversarial. That's just going to add even more pain on what a family's going through. So what are some steps to prevent futility conflicts? I'm going to give you 2 don'ts, and I'm going to give you 8 do's, and then we can have some conversation. Don't dwell on non-beneficial treatments. Like, if you think about it, we don't do a lot more for a patient than we do. Like, when a patient or a family says, we want everything, my first response is, oh, please, you really don't want everything. Like, if you knew what everything was, we can do so much. And some of it's not applicable. Some of it is going to be clearly more burdensome than helpful. So rather than talking about all we're not doing, we should talk about what we are doing. And I think sometimes in our attempt to be transparent, we cause ourselves problems. So say so many of our limitation of treatment orders are based in the negative, right? Do not intubate, do not resuscitate, do not ECMO, or whatever it might be. And in our handoff culture, sometimes we feel the need to review that and confirm that, which is noble in intent. So if I'm coming on for a night shift, I might say to a family, so just to be clear, we're not going to resuscitate, we're not going to intubate. And if I were a family, essentially at some point, I'm going to be like, there's so much stuff you're not doing, what the heck are you doing? And I think it's much more appropriate to say, we are going to focus on this patient's comfort. We are going to focus on trying to continue what we're doing right now and focus on the positive. And don't use the F word. So we might think we know what we mean by it, but hopefully by this point in the talk, we realize we probably don't know what we mean by it, or maybe we mean something different than the person we're talking to. And it comes very close and may give the impression to patients and families that we're saying it isn't worth trying to save this patient, which is clearly not what we're saying. So I think that we should just get rid of futile, because I think that it's conveying the wrong message. So what are our do's? So I think we should clarify patient goals. Remember, futility, that word we're not supposed to use, defined by the patient's goals. Benefit is defined by the patient's goals. So rather than saying, starting with procedures, we should start with goals and then go to procedures. So many times, well-intentioned people, I think, talk about, should we do CPR? Should we intubate? Should we do more chemo? Should we do ECMO? Whatever that might be. And what I try to say is, I think what we should do is we should start with more human things. We should start with what that patient hopes for. And then sometimes, especially when I've worked with adults, people will say, well, I want to be full code, or I want to get CPR. And my initial response is, no, you don't. Nobody wants to get CPR, because CPR doesn't feel good. What they want is they want to live to see another day, or they want to be able to go home, or they want to be able to see their kids grow up, or play baseball with their buddies, or whatever it might be. So I think we need to be clear about what the goal is. And so sometimes what I'll do in sort of a learning exercise is I'll challenge, especially residents, to have a conversation with a patient, or imagine having a conversation with a patient that has no medical terminology in it whatsoever. None. Just human stuff, heartfelt stuff, real stuff. And then at the end say, based on what you've told me, I think your code status or plan of care should be blank. Now, that may seem paternalistic, like I'm telling somebody what they should get. And I don't think it actually is. I think what I did is I spent a long time, and it can take a long time, listening to what's important to them, what their heartfelt goals and wishes and dreams are. And then I can say, well, I think the way we can get there is this. An analogy I sometimes use is patients, or in pediatrics, oftentimes parents, they're the captains of the ship. They get to say where they want to go. And we in the medical profession are the navigators. We tell them medically what's the best way to get there. So you might say, well, how do we do this? So this is something called the Serious Illness Conversation Guide that comes out of Ariadne Labs, which is Atul Gawande's operation in Boston. And it talks about how to have serious conversations, or serious illness conversations. And the area that I would draw people's attention to is these 6 things. Goals, which is what you hope happen. Fears or worries, which is what you hope don't happen. Sources of strength, critical abilities. Sources of strength is obviously where you find your strength to keep going. Critical abilities is what makes life worth living for you. Trade-offs is what you're willing to go through in order to achieve that goal that you stated before. And your family involvement, which is, I think, more in question with adults and more assumed in pediatrics. If we can figure out the answers to these 6 things, what are our patients' goals, fears, sources of strength, critical abilities, trade-offs, and family involvement? I think we can put that together into a medical treatment plan. Now, it's not easy to get this information. It's a lot easier to say, if your heart stops, do you want us to restart it, or try to? It's also not fast. You know, this is not a yes/no question. None of these are yes/no questions. You have to spend time, you have to listen, and at the end, you have to say, I want to make sure I got this right. Did I hear you correctly? Because maybe you got it wrong. Maybe you misinterpreted. Maybe there was a problem of communication. But if we can get these 6 things understood by us, then we can form a treatment plan. And then we can offer a recommendation based on those goals. So we figure out, these are your goals. This is the way you can achieve those. We ask for confirmation. Did I understand that correctly? And as I said before, it's not paternalistic. We should also consider the burdens. Like up until now, we've been talking about the likelihood of something working, but almost everything we do in medicine, especially in intensive medicine, has a downside. There's pain, there's suffering, there may be lost opportunities. You know, if somebody could survive 1 month outside the hospital and do what they want to do with their life, or they could survive 3 months in the hospital going through procedures, maybe they would choose the 1 month where they could actually achieve what they really want to do. We need to reframe the default, as I said before, rather than focusing all on the negatives, we're not going to do these things, or assuming we're going to do them unless we get a no. We need to reframe the default. Studies have shown cognitively that if something is a default value, people assume that that's probably what they should do. I think there are times that not doing CPR should be the default. Doesn't mean we shouldn't have a conversation. Doesn't mean that patients couldn't ask for it. But rather than say we're automatically going to do it unless you say no, puts an added burden on families. We should also utilize an approach called informed non-dissent in certain situations. What I mean by that is we talk about informed consent in adult medicine. We talked about informed assent in pediatrics. Informed non-dissent means that we provide all the information, we've listened to the patient and family, understood their goals, their fears, their worries, critical abilities. We make a recommendation. We say, based on what you told me, I would recommend this course of action. There are times when families have a very hard time receiving that there's nothing in life, I wouldn't imagine, that's harder than making these decisions for your child. And I think sometimes if we wait for families to make that decision, we put even more burden on their shoulders. So sometimes I think what we could do is say, seems like your goals are this, if I've understood you correctly, I don't think certain procedures are going to help. So unless you object, we're not going to do those things. So we're taking more of the responsibility, more of the burden on our shoulders. And I think sometimes we can even go further than that. So I will always remember I had a patient some years ago who was 2 years old and had a degenerative, undiagnosed, but degenerative, by all indications, neurologic condition. And his parents were colleagues of mine, both medical professionals. And we had had lots and lots of conversations about what to do for him if his condition got even worse. And I felt like I really understood where they were coming from. And then one day, after various ups and downs, he was admitted to the hospital and he did not look like he was doing well. He was developing increasing respiratory distress and weakness and fatigue. And he was on the inpatient floor, and he was at a point where if we were going to sustain his life, we needed to transfer him to the ICU. And his parents knew what that meant. They were both medical professionals. They knew that was going to mean a ventilator and lines and all other stuff. And I said to them exactly what I said on this slide. I said, based on what we said, that doesn't seem like that's consistent with your goals. If your goals have changed, you let me know. But if not, I don't think we should do this. I don't think you want us to do this. So I think we should maintain all the treatment we're doing right here, but we shouldn't escalate. And I asked for confirmation from them. And they couldn't give it to me. Like, these are incredibly thoughtful, intelligent medical professionals who had done incredible advanced care planning. And in that moment, when they were faced with the loss of their child, they were emotionally paralyzed for reasons that I don't think it takes a whole lot of imagination to understand why. But we work in a default system. And as we all know, the default value is we do everything for everybody unless there's a decision not to. And they weren't giving me the confirmation that I would typically require in order to do that. But I felt like I understood them. And so I said to them, in about 5 minutes, I'm going to step out and I'm going to go to his chart and I'm going to write a do not transfer, do not intubate, do not resuscitate order in his chart. And if you want to stop me or say something has changed, you can. But if not, I'm pretty sure that's not what you want for your child. And I don't remember exactly what we said for the next 5 minutes. But they didn't talk about anything medical. There was a lot of silence. There was a little bit of chit chat. And I said, I'm going to step out now and do what I said I was going to do. And they didn't say anything. And so I wrote that order. And he died very peacefully that afternoon. And it was incredibly hard. What was even harder for me was when we met again, I accompanied them to meet to discuss the autopsy results because they needed to understand what had happened to their child. And I thought to myself, if there was something we missed, if there was something we should have done differently, like, I wasn't a passive observer on this one. Like, we were in this together. And I just felt this incredible weight on my shoulder. Not the same as their weight. It doesn't compare to their weight, but it was a weight. And it turned out that there was nothing we missed. But this is something I think that we are called to do as physicians, that we shouldn't just ask questions and take answers, that we need to be engaged with families and understand what they're going through to the best of our ability, understand what their goals are, and try to carry some of that burden with them. What if there's not a clear plan going forward? I think there are some mediating steps we could take. One is we could offer a time-limited trial, which some people call a provisional intensive care, where we say, well, let's keep doing what we're doing for a period of time. That makes sense, like long enough for it to work, but not so long that if it's not working, it incurs additional burden. And then at the end, let's revisit once we have some clearly established waypoints, like this will have worked if his blood pressure is better or if his vent settings are going down or something like that. It's not a binding agreement, but at least it creates a bit of a perspective to say, this is a time that we can revisit it. And I think it also might spare families the burden of having to make decisions every single day. Like I often say to families, if you make a decision today, trust that it was the right one, and then just love your child until there's a time to make another decision, which means something is either much better or much worse, or enough time has gone by that we need to reevaluate, rather than having to question yourself moment by moment. Consider a do not escalate treatment order. So rather than removing things, is there a way that we can say, let's just keep doing what we're doing, and if the patient gets worse, then it's not because you made a decision to remove everything. It's a sign that his body is giving out or her body is giving out. And steps like that will resolve about 95% of futility conflicts, according to a recent review. But what if, despite all those thoughtful steps, the patient or family still requests treatment that you feel is not beneficial? So in those extreme cases, some people say you could unilaterally forego the treatment. You could just say, we're not going to do it. And some people say that the reason for that is to prevent suffering, especially prolonged and burdensome suffering. Or you could provide it. And I have to confess, I'm in the provided camp for a variety of reasons. One is sometimes we're wrong. Sometimes patients surprise us. There may be times when a patient may be beyond suffering. So if there's a patient I think is suffering, that's a big deal. There are some patients who are so sick that I don't think they are able to suffer anymore. And I worry about the suffering of the parents. And also concern for whether or not someone has the ability or the opportunity to advocate for themselves. Certainly when the patient asks for something, that's important, when you have patients who are able to express their own views. And when the family requests it. And so I want to leave a few moments for questions, but I do want to make sure we cover this. So Bob Trug, who's an intensivist and ethicist at Boston Children's, wrote an article now 10 years ago that I would really recommend for anyone who's interested in this field. And he talked about this powerful experience that he had, where there was a patient who was clearly dying, and they talked to the family and said, we don't think we should do CPR on this patient. We really don't think it's going to help. We think it's going to incur burden. And the family kept saying, no, we want to do everything. We want to do everything. And this was causing a huge amount of moral distress on the part of the staff. They felt like they were going to inflict pain on this child. And one night, this patient experienced a cardiac arrest, and they did CPR. Like, they did it well, as CPR is meant to be done. They put in chest tubes. They did full resuscitation, and they were unsuccessful. And then they declared him dead. And a few minutes later, after they had sort of tried to clean up everything in the room, the father arrived because it was the middle of the night. And this is what Trug said. And they were afraid. They were afraid that the father would say, what have you done? And Trug says, what surprised me the most was when the father gently opened his son's shirt, revealing all the puncture wounds and bruises from our failed attempts to place a subclavian catheter. He looked up at me and said, I want to thank you. I can see from this that you really tried. You didn't just give up and let him die. Although the interests of the patient are always primary, at the end of life, there are times when the interests of the patient begin to wane while those of the family intensify. Family members may live for years with the psychological after effects and regrets of end-of-life decisions. By sometimes agreeing to provide quote-unquote futile CPR, we send a message to our communities, not that clinicians can be bullied into performing procedures that good medical judgment would oppose, but that our hospitals are invested in treating patients and families with respect and concern for their individual needs. And so the last thing I would mention is this notion of what some people have called tailored codes, which is to say, rather than make a unilateral decision and say, we're not going to do this because we somehow are certain it's not going to work, I think it's more appropriate to say, we're going to do things the way they're meant to be done. The purpose of a code is to try to resuscitate somebody until it becomes clear that that's not possible. And there are certain situations where our pre-intervention probability of failure is so high that we don't need to be coding somebody for 45 minutes. We shouldn't do it in sort of a show way. We shouldn't do it in a fake way. We should do it in an appropriate, integrity-filled way until we get to the point, which may not take much time, to say, we did it because that's what we were called to do, to honor the family. And now we know for sure that this patient cannot survive. So in summary, we try to prevent rather than react. We use some tools like time-limited trials, informed non-dissent, do not escalate treatment orders, and tailored codes. Lots and lots of references, and now an opportunity hopefully for questions and conversation. And just a big thank you to Nancy and her family, and for giving us an opportunity to talk about really important things.
Bob, this is Maggie. I just want to say thank you. It's wonderful to see you, and it was a really excellent talk. I think we've had so many struggles this year, I think compounded by the stress and anxieties of COVID. We've had so many troubles with these very issues this year that I think this came at a perfect time, and I'm glad. Thank you.
Thanks, Maggie. Nice to see you.
Thank you so much for such a wonderful talk, and I want to echo the comments in the chat box, just saying what a thoughtful and compassionate approach you have. The chat is open for any questions, or people can also feel free to unmute to ask Dr. McCauley your questions.
I just want to say thank you, Bob, for a fabulous teaching and learning session. And the one little note I made to myself in the mid portion where you were talking about kind of going through the key topic areas with patients and families takes time. I am thoughtful about the investment of time upstream or upfront, pays off in dividends, not only, especially importantly, in better outcomes, I think, but also it saves time later because you can refer back to, well, I remember we talked about this, you know, sort of doing that at the beginning really is such an investment in so many ways that pays off down the road.
Thank you. Appreciate that, Nancy. You know, I think when we talk about hope too, another thing to mention is all those hopes and goals that are part of the Serious Illness Conversation Guide. There's usually more than one. So I think we don't ask about hope or goals as often as we should. And when we do, sometimes we take the first one, but usually there's a lot of them. There was actually a study a few years ago that showed that the median number of hopes, individual hopes for patients or parents of kids with cancer was 7. So they hope for a lot of things, and some of them don't always go together. And so oftentimes what we'll say is, what do you hope for? Thank you, once you've answered. And then we say, what else do you hope for? Because sometimes we can't achieve the thing they most hope for, which is kind of obvious, which is cure. But if we know what else they hope for, maybe we can shift to that if what we most hope for we can't achieve.
Dr. McCauley,
Bob, this is Renee. Oh, sorry.
Go ahead,
Go
Renee.
ahead.
Go ahead, Renee.
Thanks. So Bob, one of the things I am struck by when I find myself in these sorts of situations is the challenge of the large, ever-shifting medical, quote-unquote, team. And a number of the skills you describe or the scenarios you describe feel like, or I recognize them as very often intimate one-on-one conversations. And I'm wondering what strategies you've found to convey information to everybody on the team who needs to know it, so that the team can be consistent in their messaging and their language, as well as how do we make sure that in this kind of gray zone area sometimes that we make enough space for everybody on the team to speak their part?
Thanks, Renee. That's a great question. So I think it's hard in our handoff culture with multiple teams involved. And oftentimes the patients we're talking about are well known to us and have spent a long time in the hospital and have generated a big, big medical team. So you guys probably have it at Hopkins too, I'm sure, but like our Epic system auto-populates notes with all kinds of, like problem lists and things like that. And sometimes, it's a 6-page note and it's really only like the last 3 sentences that mean anything once you get to the assessment and plan. So my notes right now, I've actually taken the serious illness conversation guide, and like the first thing I put, because I'm like, I don't know how long someone's going to take time to read this thing, is goals and fears, which I think are flip sides, right? So goals are what you want to have happen, fears are what you don't want to have happen. And then critical abilities and trade-offs, which are also flip sides. Critical abilities is what makes life worth living, and trade-offs is what it takes, what you're willing to go through to get there. And then I also put in the other things from the serious illness conversation guide, sources of strength and family, but those are, especially family, is kind of assumed. And I try to put that front and center. Because I think that might be what, as a palliative care consultant, we bring to the table. Like I'm not going to tell an intensivist, how to raise their blood pressure if they get hypotensive, because that's not my expertise, and they're way better at that than I am. But what I think we can do to add to the conversation is to not only contribute that which may not have previously been identified, but also put it out there and say, this is not just important, this probably is the most important thing that's going to frame everything else that we do. And so that brings it into the conversation and puts it front and center. It doesn't answer all the problems or of communication or handoffs or things like that. But if we can continue to refocus and bring us all back to where we started, which is, what is this family hoping for and what are they afraid of? Like if we just get those 2 things on the table, I think that'll move the conversation forward. Ray, were you going to say something earlier?
Yeah, I was just going to relay the situation when Robbie died, the night he died, and getting back to your discussion about what do you do and what don't you do. A real situation happened where the resident, I assume the resident, was trying, when Robbie went into, critical path, he called for a heart needle, I assume for adrenaline or something like that. And Robbie's doctor, Dr. Hayes, his oncologist, just kind of waved him off and said, no, he's had enough. And that was that decision, right, of what's enough and what's futile. But the fact that Dr. Hayes had built such a relationship with us and our trust of him made that not a conflict. It was not like, what do you mean you're not going to try something? We experienced enough of Robbie's suffering that we were at that point. But the fact that Dr. Hayes had gained our trust over those 2 years made that a lot better. So I think back to Nancy, what Nancy said and what you said early on, the early discussion of these things and building a trust in people, not only for their medical judgment, but for their human judgment over a period of time with a child's life is really important.
Yeah, thank you for sharing that. I think that it feels like the resident probably was treating the patient who happened to be in that bed, and Dr. Hayes was treating Robbie and knew what was in your heart and was combining what you hoped for your son with his or her medical knowledge. And that's what I think we should strive for.
Great. It does look like there is a question or a comment in the chat box from Emily Johnson saying thank you for the presentation, and that she sometimes struggles with the article that you cited, because reality is in end-of-life situations, we will ever only know one side of the response. We don't know what the family's response would be if the medical team stopped CPR in any of the other phases of care on the scene, in the ED or in the PICU. In her practice, she's amazed how families make meaning out of whatever situations play out. She finds that it's more trust and relationships with the team that matter versus the interventions that are provided at end of life.
Emily, I really appreciate that thoughtful comment. I want to be really clear, like the Trug article probably generated as many letters of response as any article that I've ever seen in the New England Journal. And let's just say not all of them were positive by any stretch. And I think probably most of them were very, very negative. The bottom line is we'll never know what would have happened if we did things differently. And I think that your emphasis on relationships is really spot on. That if we're doing the best we can and we have established a sense of trust, and patients and families know that we care about them. I don't mean to say that that's all that matters, but I think that's the heart of what we're doing. And I also don't mean to say that every single case should have gone down the same way that Dr. Trug describes that case. I think he said in that moment, he made a call and that was important. And he stood by it, and I appreciate that. But there may be situations that when the details are different, like every patient is different. And when the details are different, it might call for something different.
Great. Well, thank you so much for such a wonderful talk and such a wonderful discussion. We're out of time, but wanted to thank you so much again.
Thank you all very much. It's nice to see some friendly and familiar faces, and it was really an honor to be here. And thank you to the Hutton family for making this possible.